Good morning. Good morning. We're going to get started. It's exactly 10:15. And for anyone that's standing, if you could please find a seat. There are plenty of seats available, so you might have to squeeze in, but I think it's preferred that people not be standing. So, good morning and welcome to the Physical Therapy, Respiratory Therapy Year in Review Workshop. And a few things I have to say up front before I mess it up and forget. These are 15-minute sessions with a Q&A after. You can ask questions in the app, or you can step up to the microphone. So please don't hesitate to ask questions. I feel like physical therapy and respiratory therapy really go together. So I'm messing up already. I'm Andy Reed. I'm a respiratory therapist at Riley Hospital for Children in Indianapolis. My co-chair is Sean Duffy, who's a physical therapist at Johns Hopkins in Baltimore. I've been a CFRT for about 10 years now. And I was only fortunate enough to work with a CF physical therapist for a brief period of time. And I feel like we really mesh well. Physical therapy and PT go together. Another thing I always like to mention in these sessions is that each one of these 15-minute talks represents a great amount of work by the people that are putting them on. Each one's a published abstract that has a poster in a poster hall. So if you're really interested, you can see that information also on the posters. So don't hesitate to ask questions. And my final thing I always say is never be afraid to take a step, to find a project, to find something that you want to work on. When I was an RT at the bedside, we did great work, but I never felt like I was really encouraged to say, I think we could do this better. In a CF clinic, when you say, I think I can make something better, somebody is going to say, you go make that better. You do that. So if you find something that you're passionate about, whether it's PT or RT, where you really want to make a difference in your center, write that abstract, do that research. It's how we move forward. So our first speaker today is Sean Elliott. He is bio stuff. He is a physical therapist from Johns Hopkins in Baltimore. He is a pediatric physical therapist in the Pediatric CF Center. He's been a CF physical therapist for about 4 years. Much like Sean, he's very passionate about physical therapy, making exercise, getting our patients healthier through physical activity. So please welcome Sean Elliott.
Thanks everybody for being here. If you can't hear me, if I drift off a little bit, just shout up and I won't take offense to that. So today I'm going to be talking to you guys about the feasibility of doing the A-step test in a pediatric CF clinic. So no disclosures. So how we got here. Everybody in CF clinic gets the FEV1, but that value alone gives some limitation, right? It gives you a good number, but it doesn't really give us a good value to determining exercise capacity. There are other tests we can do. So the gold standard is the CPET, the cardiopulmonary exercise testing, which gives great information. However, it requires a lot of equipment, a little bit of time. Not everybody has that availability to do in their clinic. So we resort to field tests. So some field tests that you all might be familiar with are the 6-minute walk test, the modified shuttle walk test, and the 3-minute step test, all of which are fine for what they are, but they do also have some limitations within themselves regarding space. Some clinics don't have the space available to do some of these tests, and the 3-minute step test can also have a ceiling effect, especially in our healthying population. So when you're looking at the Alfred step test, the A-step, that one is what we wanted to utilize in our clinic, in a pediatric clinic, to see how can we apply this and utilize this information to give us more insight to that exercise capacity in our patients. So I want you guys to think about kind of like, what are we really utilizing this exercise test for in clinic? Why do we need it throughout this talk and also later talks? So the A-step, for those who are unfamiliar, is an incremental step test. Is intended to be a maximal exercise test, externally paced, like the modified shuttle walk test, comparatively to the 6-minute walk test and the 3-minute step test, which are the 6-minute walk test is internally paced. 3-minute step test is externally paced, but it doesn't have incremental changes. So you're on a step, as you can see here, and we're measuring heart rate, SpO2, and subjective measures of dyspnea and light fatigue throughout. The test at total time is 16 minutes. We instruct our patients to go to fatigue. So it's intended to be a maximal test. And how we classify maximal effort is 90% of age-predicted heart rate max, and then the subjective dyspnea and fatigue of greater than or equal to 9 out of 10. So the ASTEP has been determined to be feasible in a population with CF. It's useful in assessing exercise capacity. It is useful as a maximal test itself. It's safe in adults and 11 children. And this is where we wanted to kind of take it further. They only did it in 11 children, which is great, but we wanted to kind of take that a step further to really look at, doing it with more children in the CF population. And you can see our average time what we got was around 11 minutes. Setup time or recovery time, give or take 15 to 25 minutes. So we're looking at it more in the pediatric population to get more numbers there. So our demographics, we had 73 individuals, all of which completed 86 tests. So we had a few tests that were duplicates, and it's actually 74 individuals instead of 73. We had 12 individuals that completed duplicate tests, about half female, all for the most part in the teenage years. We went 12 and up, just for size of the patient and anticipated sort of coordination. Relatively healthy population, as you can see here by the numbers. The median FEV1 was 99, which is great. And the one thing too I want to point out is that majority of our patients were on highly effective modulators. The original ASTEP feasibility paper was pre-highly effective modulators, so our population is slightly different than that original feasibility study. But as you can see, a generally healthy population that we had. So I'm going to orient you to the graph first. So on the x-axis, we have the number of participants. And on the y-axis, we have the ASTEP levels completed. So the number of participants in each of the levels that they completed. And the blue is those that achieved maximal effort based on the criteria of heart rate and subjective Borg measures. And the yellow is those who did not. And as you can see, the general kind of thing I want to point out is as participants were going further in this test, doing more levels in this test, more of them were reaching that maximal effort. As a total, majority of our patients reached that maximal effort when doing this test. And the other thing that I want to kind of draw your attention to is when you get down in the lower end of it, you do have some of those that are in this maximal effort in the lower end, below 8 minutes really. Specifically in the 5 and 4 minutes, I looked more specifically at those maximal effort criteria in those patients, and it was not for heart rate, only for subjective measures. So keep that in mind. Subjective measures are obviously subjective. We like to use objective data to have best, to gather the best information. So the 4 and 5 minute were only subjective measures rating maximal effort, and then I believe only one patient in the 6 and 7 were for heart rate for maximal effort. And then the main thing too in this one that I want to draw your attention to is top bar here. So we had a lot of our patients. There are 19 patients, that was 22% of the tests that completed the test in its entirety. So they completed all 16 levels, which is great. This is a healthy population. They're doing really good. And one of those patients didn't achieve maximal effort based on heart rate and subjective measures. So think about that a little bit, and we'll kind of tie back to that. Now this next graph, we're looking at the patients who exceeded or went beyond, they continued to do the test beyond when they achieved maximal effort based on these criteria. So we kind of looked at the data a little bit further to break down, because you can see we had a lot that completed the 16 levels. So we wanted to kind of look at that a little bit more. Like when did our patients reach this maximal effort, and how many of them kind of continued further beyond that? So on the x-axis, we're looking at the number of levels exceeded, 1 through 5, and on the y-axis, we're looking at the number of participants, and specifically how they rated themselves subjectively and what their heart rate was doing. So we had a lot of individuals who were in this the 1, 2, 3 steps beyond, levels beyond when they reached maximal effort. And you can see that the rating with heart rate max and leg fatigue seems to be highest across the board, and which is important, one, because when you're looking at heart rate max estimation calculations, they can oftentimes not be the most accurate for pediatrics. So you have high heart rate, they're reaching their maximal effort based on heart rate, and they're continuing to go beyond that. And they're continuing the test even though they're at this 90% heart rate max based on the estimation calculations. Same thing with leg fatigue. A lot of these patients are rating themselves high in leg fatigue, but continuing to do this test. And the yellow here is the dyspnea. So that's the one thing too that's like kind of important to note here, is that fewer people continue to exceed the levels beyond maximal effort when dyspneic. So keep that in mind. Perhaps those, especially in the pediatric population, when you're utilizing Borg subjective measures, perhaps dyspnea could be potentially a little bit more accurate comparatively to heart rate estimation calculations and leg fatigue subjective measures. So the big thing here that I wanted to conclude with is the A-step is feasible. We did it with a lot of our patients, and they tolerated it really well. It was safe to do, and we had no adverse effects. Some maybe weren't happy about doing it, but they did it anyway. And it provided us good information to exercise capacity. When you're tying this value that we get, how far you're able to push yourself on an exercise test, and lump that together with FEV1, you can get some valuable information with that. And a lot of our patients went beyond maximal effort. Half or a little over half of our tests, they went beyond when they reached the categories of maximal effort. And going back to the point of subjective measures may not be the most accurate for pediatrics, potentially, and just humans. But when you're thinking about subjective measures, kind of take it with a grain of salt. Potentially dyspnea is a little bit more accurate than leg fatigue based on the other graph. And then heart rate max calculations could also over or underestimate as far with your patient population as well. So looking into the future here. So specifically, we had a lot of patients that completed the 16 minutes. So we have a healthy population, comparatively to the original A-step feasibility study. Our population appears to be a lot healthier. So potentially there could be a ceiling effect in this test with healthy pediatric patients with CF. So looking into maybe there's some modifications that we can make to the test itself, maybe, who knows, to have a better understanding of a maximal test for our continuing to be healthier population. And then how are we going to really utilize this information? Right, you get this information, great. You have FEV1, that's always going to be something you have, and you have this number of how they tolerated doing an exercise test. You want to take those two pieces of information and kind of tie it together. Do our patients have specific goals that they want to achieve? Do they want to get involved in some sort of activity? What sort of measures or modifiable changes can we, help with or give recommendations toward to help them achieve those goals? If you're noticing they're becoming a lot more dyspneic on testing comparatively to leg fatigue or vice versa, maybe you focus on more cardiopulmonary exercise recommendations, or maybe you focus on more resistive recommendations. Comparisons to CPET as well as the gold standard and VO2 max to just gain a better understanding too of how our estimations for heart rate max and how our patient subjective measures for how they're doing to try to hone in a little bit more accuracy there with those numbers as well. That could be a great avenue to go down. I know that requires a lot more equipment, but trying to compare a field test to the gold standard and get the most sort of accurate or precise information that you can get would be awesome. And then what we want to look at too, specifically what I would like to look at in our clinic is the patients who have completed multiple tests, how their results change over time, specifically to what kinds of things we are addressing with them. If they want to do anything, like we talked about, some sort of modifiable changes that we can make, how are our patients changing over time? How does that compare to what their FEV1 is? How does that compare to what they're doing in their daily activity and if they're involved in activities or sports or not? how that changes within the individuals themselves. And then just tying back to, it's important to exercise, right? And this is a test that you can it highlights that aspect as well in our patients, is that the importance of activity and exercise and incorporating that into your just daily routine as a quality of life and just being healthy, but also with CF as well. You can utilize exercise in other ways for multiple reasons, but it can be beneficial to airway clearance. It's just beneficial to the body in general. So you can utilize this test in clinic to kind of highlight the importance of that, and maybe point out some of the deficits that patients may not be aware of too. So poster shout outs too, that this particular poster is 497. There's others that are involved with this data as well that kind of go into different avenues. 509 is the talk a little later for more information on what we found with this information. And then 604 goes into more nutritional aspects as well with comparison to BIA. Thank you guys for listening, and open any questions.
Thank you, Sean, for a great talk and really nice job. You got a bunch of questions on here, which is fantastic.
Somebody at the mic.
Oh, sure. Please go ahead.
Hi, Lisa Morrison from Glasgow, adult CF. Brenda's already done the CPET versus the ASTEP correlation. So there's a paper which shows that the ASTEP is a really good correlation, a significant surrogate for CPET as a field test. So that part's been done. So you can look at that and maybe do it in a pediatric population because she's done it in an adult population.
Cool.
And in my population of adults, we've increased the step height to 25 centimeters to try to see if we can max them out that way. So obviously some of our adults are very good. We have our young people come to us at 16, and some of them have lung function of 120%, as you've identified. Mm-hmm. And a lot of them can complete at 16 levels as well. So you increase the 25. Now, this is not validated, obviously. Brenda would have a kitten. But if you increase it, you can maybe max out their heart rate a little bit quicker if you want to do that. And the question I had really for you was, does the dyspnea correspond with a decrease in saturations? Because you didn't mention saturation decrease. Thank you.
So, touch on the saturations. We had none of our patients desaturated below 90%, which was great, and none of them required oxygen. To touch on the step height too, I've had that thought as well, as far as what kinds of things we can change, with our patient population getting healthier, right? The step height's a great one. One, for increasing it to make it more difficult, but also potentially decreasing it for younger children as well. We stopped at 12 just because of size and coordination. We tried it with a couple younger. Sometimes it worked out well. We went to 10 with a couple. That's not included in this data, but just as a trial. But things like that to consider as well for just modifications that we can make.
My question was about the age, so.
Oh, cool. Great. Oh yeah. There's also a roundtable after this as well if you want to chat more about things.
And I got one from the iPad for you. How often is the ASTEP being completed, and how do you compare patient results to themselves to guide clinical decision making?
Yeah, so that is really where I want to take this into the next year, is really honing in on the utilization of it. So we completed it as part of our annual physical therapy assessments over the last year. And then now, as we're kind of past that, we're more basing it on an individual basis. So, how did the patient do previously on the ASTEP? If they completed it, then we're kind of saying, are you still doing stuff? You still feel good? We probably don't need to do this with you. If our patients, maybe didn't do as well as they had wanted, or like we're looking at it and saying, maybe they could have done a little better, we might do it with them again. Also looking at kind of what they're doing, and is anything changed over the last year? So we're kind of looking into, can we utilize this as part of our annual physical therapy assessment? Sure. Do we need to do it with everybody? Probably not. So we're kind of honing in on trying to figure out the best utilization of it. Because it takes 15 to 25 minutes. So that takes a good chunk of time out of clinic. So that's always a consideration. If you have a busy clinic, it also might not be the best to try to utilize this with everybody. Maybe you can get one or two in, but always time for our patients is considered. Thanks.
And are there pediatric versions of the Borg scale? Which version did you use? How did you kind of administer that?
Yeah, we that's another thing that we played around with a little bit. We just used the 1 through 10 scale. We did have visual printouts as well that we used for our patients. Some of them had the number markers on there that had like verbal, like written out sort of criteria based on how they should be feeling. The one that it's like the climbing person as well. So playing around with utilization of that as well, I think is really important for pediatrics to have a better understanding of how should they be feeling, and maybe orienting them to that before you do the test as well would probably give you a little bit better accuracy. Just saying like 1 to 10 or 0 to 10 to a child, they may not have a good understanding of what that actually feels like. Maybe they know what a 10 feels like when they're sprinting hard at the playground, but the middle categories are a little bit more challenging for kids to kind of conceptualize and determine.
I got one more for you. And does coordination and pacing impact the child's ability to do the test? If so, how did you navigate that?
Yeah, oh, for sure. That was a big thing that we found. And I mean, it's all people too. Like this test requires a level of coordination because you have to follow to a specific cadence, and that increases every minute. So some are good with tempo and cadence, some are not, and that's just all humans. Especially just in kids too. Some were great, some were not. We did our best to, we didn't have like a cutoff of if they were slightly off the cadence, I wasn't stopping them, because this is intended to be a maximal test. Like if you can continue going, I would just sort of remind them, try to keep up with it, and like give them some, cues to kind of help, step, whatever. Finding ways to help them to get on the cadence or, go a little bit faster. But what we were really looking at was how long can they continue to do this before they really need to stop. So I didn't want to cut them off before they felt that they needed to stop themselves. But yeah, coordination is definitely a factor. Also, motivation is a factor as well, internal and external motivation from parents or whatever, promising McDonald's. We had a kid that probably shouldn't have completed the test, that completed the 16 minutes because he was promised McDonald's afterward. But it ended up being a maximum test, which was great.
So that actually kind of leads to a question that I was thinking when you were doing your presentation. We do a lot of simple stress tests in our PFT lab, and we coach pretty vigorously sometimes. How were these? Were they coached? Were they driven? Were they encouraged to go farther and faster continually, or were they allowed to work at their own pace, so to speak?
Yeah. So I would always tell my patients, this is intended to be a maximal test. You're going to get sweaty. You're going to get tired. We want you to really give it your all. Some didn't really like that, and they were kind of like, I'm like, when they reached a certain point that was just over the cusp of, too much effort, they would stop. They would say, I'm tired. My legs are tired. And you could kind of see that too when you look at the numbers a little more in depth. You'd see their word rating would go from 2, 3, and then they get to a point, and then all of a sudden they're at a 10, right? And you're like, is that accurate? I don't know. And there was more of that like internal motivation to continue that effort to push yourself. So I would always tell them, I want you to be sweaty. I want you to really work at it. And there were a few cases where some kids would kind of want to stop, and I'd say, no, keep going. You can do this. Like you got this. You can keep going. And they would continue, which was great. But yeah, that's So
I think we got time for one more, and then one else.
Real quick. So how do you navigate around the parents when you're coaching, like Andy said, kind of vigorously? How do they tolerate that? I mean, do you leave them out when you're testing, or do you allow them back in?
No, they were in the room. For the most part, I mean, some of our maybe teenage population were, if the parents weren't there or whatever, they drove themselves. But most of our parents were in the room, and they seemed to like it a lot. They liked to see their kid doing some sort of activity, having some sort of like internal competitive nature. Some of the kids potentially didn't like it. Maybe the biggest factor I would say, to some extent we saw was just like timing. It takes a bit of time. So people were in a rush, or they're like, oh, you gotta do it. We've been waiting here for so long, and now you're make us do this step test. But the parents seem to be pretty engaged with it, and sometimes helping their children to like actually motivate them to do better, which was sometimes helpful. It had a little bit of the piece of external motivation.
Thank you.
Yeah.
All right.
Cool. Make sure.
Cool. Let me pull up these slides. Great. And our next speaker is, sorry about this feedback, Kathy Vasquez. She is the program coordinator and a registered respiratory therapist for the Adult CF Center of Central Texas. She has been practicing respiratory care since 2007 and has participated in the CF Foundation mentoring program as a RT apprentice, and in 2022 as the program coordinator apprentice. In 2020, Kathy became the Adult Center's program coordinator. She continues to attend various local CF Foundation chapter events and is an active member of the Central Texas CF community. She continues to find ways to improve and grow with her CF team. Please join me in welcoming Kathy.
Hello, good morning. This is terrible. Jeez. Better? Okay. I can stand way back here on this side. Thank you all for coming this morning. Happy Respiratory Care Week to all you respiratory therapists out there. Woohoo! I do not have any disclosures. So
Why don't you just use this microphone?
Let me just turn that.
I didn't break it.
No, it wasn't you. It's not you.
That might work.
Oh, thank you, thank you, thank you. Can everybody hear me okay? No? Hello, hello, hello?
It was supposed to work.
Okay, hello. Oh, okay. Absolutely, yeah. Mm-hmm.
We need a slide for technical difficulties.
Hello, hi, hello, good morning, hello, good morning, good morning, good morning, hi. Yay, yay, yay. Oh, I need to stay close though, don't I?
Thank you.
Okay, so my abstract was over active and passive airway clearance. Can everybody still hear me okay? So is active or passive ACT better, or is this becoming rhetorical? The Adult and Pediatric Centers of Central Texas, sorry, let me put my little notes down somewhere. We did a joint project together, so I worked with Cheyenne. She's my counterpart over there at the Pediatric Center, Dell Children's. We did a retrospective study to look at FEV1 and ACT of choice. Our study aimed to see if patients' FEV1 had improved by at least 5% after a change in their airway clearance of choice. We did have some inclusion criteria. Those included the patients that we looked at were 10 years of age and older. They must have had a change in their airway clearance method, and they're performing their airway clearance more than 50% of the time. So that's, like once a day. Some of the things that we considered were they on or off their modulators? And then we defined exercise as having an increased heart rate for 20 minutes or more. And that was all patient reported. So just a little quick history on airway clearance, because I'm a nerd for history, but don't ask me about it because I won't remember. Back in the 1910s, chest physiotherapy was first advocated in 1915. In 1930s, postural drainage, it had been around for a little bit, but it was first described by H.P. Nelson in 1934. Autogenic drainage came around in the 1960s and was developed by Jean Chevalier in 67. Sorry, I have another little note over here. Just a side note, back in 1955 was when the CF Foundation was established. It was established by parents seeking better care for their children. So this really drove research for airway clearance. In 1970s, active cyclic breathing and PEP came around. And then the high-frequency chest wall therapy was in 1985. There were researchers in University of Minnesota that were developing therapeutic devices. And then in 2010, so a lot more recent, oscillation and lung expansion started to be developed. In 2013, exactly, it was first used for acute settings. So our airway clearance options, we described active ones as huff coughing, autogenic drainage, active cyclic breathing, positive expiratory pressure or oscillatory positive expiratory pressure, and exercise. So anything that help patients get their lungs moving, not just sitting, but moving, right? Passive airway clearance we described as chest physiotherapy or postural drainage and percussion, high frequency oscillatory ventilation or VEST, acoustics, and then oscillation and lung expansion therapy, OLE. Some of the less common options at our center are autogenic drainage and active cyclic breathing. And then passive, I think we have like one patient that does acoustics. And then we're just now starting to build up our OLE population. So some of our tracking points included our pre-FEV1 date, the absolute number for FEV1, and then the percent predicted. We also monitored the post-FEV1 date, the absolute FEV1, and then the percent predicted. Just a side note, our pre and post-FEV1, we try to collect around the same time of the year whenever possible. We also collected data for pre and post ACT choices. Obviously, that's what our project was about. The approximate date of their ACT change, and if they were on a modulator, when they started that modulator, if applicable. So what did our data show? Our cohort consisted of about 86 patients that met this inclusion criteria. There were 74 patients that were on modulators and 12 that were not. Ironically, there were 74 patients that used passive form of airway clearance. Those may or may not have been the same patients, but so they used it as their pre-method of ACT choice. And then only 3% or 3 patients use a passive option as their post-ACT option. What did we see as far as changes in airway clearance go? Our pre-ACT preferences included 74 patients were passive, 5 were active, 1 did both, and 6 of them did nothing. After their airway clearance preference change, only 3 of them did passive, 44 of them did active, 35 of them did both passive and active, and then 4 of them did none. I kind of just want to point out that if you're looking at active, both, that option, it's a weird way to say it. So active option and then both option, there were 79 patients who used active or both after their ACT change compared to just 6 before. So many more patients do an active or both afterwards. What did we see in their FEV1 changes? Their absolute numbers, the pre was 2.68 liters, and their post was 2.97 liters. And percent predicted, it was 87% pre-change, 91% post-change. So an improvement of about 4%. So why didn't we see a bigger increase in FEV1? There's many reasons why we didn't. These are just some of the ones that came to my mind. If you have any others, please bring them up. Progression of the disease. If there's any new diagnosis like asthma or pulmonary hypertension. Patient's effort on any given day. You know, they come in, they're having a bad day, it's cold outside, they just don't want to be here, we're taking too long for whatever reason. And then we did opt to not use an average PFT just because there's too many variations with, again, when patients come in, like there's just too many variations for PFTs if they're sick or, again, how they're feeling that day. Other variations are time of day. Again, some patients are like, I'm an early morning person or I'm an afternoon person. If there's any local allergens or mold, the air temperature and humidity, respiratory infections, if they've had recent surgeries, or if the patient just pre-medicated prior to their visit. There was a study done in the Midwestern USCF Center that found that average lung function peaked in February and then dipped in August. So with FEV1 fluctuating 0.81%. Another study suggested that warmer temperatures decrease FEV1. We also have to consider natural decline in lung function. There was a study that normal lung function, FEV1, can vary up to 12% or 200 milliliters from baseline in a short term. And then Ponce et al. Noted that for non-smokers, a natural change in lung function decreases approximately 30 mLs per year. And that's for a healthy patient. So, in conclusion, that was a quick one, sorry. Our FEV1 only improved by 4%, which was just under our expected goal. We know that active and passive airway clearance are equally important and effective. We also know that patients should be encouraged to continue some form of airway clearance, whichever and however it fits into their lifestyle. So again, while our FEV1 did not increase significantly, there is data to suggest that use in both active and passive can slightly increase FEV1 compared to just passive alone. Moving forward, we will continue to encourage our patients to perform whatever choice of airway clearance they want. We will also continue to monitor that FEV1 and ACT adherence. And then if we wanted to dive a little bit deeper into it, we could start looking at chest x-rays before and after. While I was waiting, I thought about it. This might be a little bit difficult because we don't do chest x-rays yearly anymore. So it would be an additional testing that would have to be done. References. And if you guys have any questions, feel free to ask away. Hi.
That was great. I think so. No?
Just yell.
Thank you very much. So I come from London, and I completely agree that the active forms of airway clearance are better. So it's nice to see your data for that. I mean, I think my comment would be that probably it's the measure that you use. FEV1 we know probably isn't that sensitive anymore.
Right.
Some of our work shown that it doesn't really change enough airway clearance for us to use that as the marker. So I think the fact that it changed actually for you is really good. That probably does show that those actives really are much more effective. But I'd probably just sort of say I think maybe imaging, CT scanning, or something like that, clearance index, if you can bring those into your assessments, would probably give you a bit more of a result on it. But
Oh, that's good. Yeah, I love that. Thank you. I didn't think about LCI. That's great. Yeah. Thank you.
Thank you. That was a very nice talk. So when we did the Canadian study comparing high frequency oscillation of the chest, or the best, to PEP, we used pulmonary exacerbation as the primary outcome measure, and that's where we did see a signal. We didn't see much of a signal for FE1 either, not a significant signal. So I think it's really the choice of the outcome measures and otherwise 4% FE1 is actually not so bad, because if you look at interventions like hypertonic saline, they haven't shown much more than that in terms of FE1 change, but more changes in exacerbation.
Perfect. Thank you so much. I appreciate that.
We have a question in the app. Was there any change in the number of exacerbations after changing airway clearance therapy? And was there an improvement in adherence to recommended airway clearance therapy regimens after they made the change?
So the first part of the question was repeated again, if there's...
Was there any change in the number of exacerbations after a change?
So we actually did not look at that. Though from another study that I am doing, I know that there is less exacerbations, but I think it's more because of modulator therapy, not so much decreased use of airway clearance or a change in that airway clearance. So I'm going to say we did not look at that for this study. And then the second part was...
do you feel there was improved adherence after they were able to choose and pick?
I would say yes. And that's just me talking to my patients. I know a lot of our patients really love to exercise. I know that's weird because who likes to exercise, but they just feel so empowered, and you're like, I do. I also love to exercise, but it's one of those like loves that you eventually find. And I think now that our patients are healthier and they feel like they are healthier, they do exercise more, and they come in and they're like, oh, I haven't exercised. And I'm like, you should really start exercising again. Like, clearly your lung function, changes a little bit. So they're like, yeah, I'm going to start running. So yes, I think there is more adherence to patients once they choose what they want to do. Yes. I can hear you, but.
So nice talk, thank you.
Thank you.
I was curious though, your passive techniques before you started your intervention or asking about preferences, were you not already doing cupping with like desk or chest PT or the other passive things? Because I know that's part of our like standard teaching with any technique.
Mm-hmm.
And going back to your exercise, like exercise without cupping isn't also going to necessarily fit. I'm just curious about pre-starting this if that wasn't already part of the equation.
Right. I think it was less of an equation in there because we obviously we tell our patients to huff cough, during their vest and exercise and stuff. So how many of our patients actually do that? I don't think many of them do. So we did kind of leave that factor out, though there are some patients that only use huff cough. So we really used it as our primary source of airway clearance and not a secondary. So if they were doing huff coughing with their vest, we would say that their vest was their primary source of airway clearance. Yeah. Any other questions?
Did your kids keep with the change that they made? Did they I'm not using the vest anymore, I'm just using active cycle of breathing and stick with that? Or did they kind of revert back to what they had previously done?
Most of them have continued with their new updated form of airway clearance. Anything else?
Thank you, Kat.
No, thank you guys.
Thank you.
I'm kind of nervous about talking into this microphone. There's been a few technical difficulties today. So our next speaker, and I hope everything works good for you, is Dr. Gary McPhail. And this kind of goes back to my beginning of being a CFRT. I was part of the apprenticeship program, and I went to Cincinnati Children's Hospital, and that is where Dr. McPhail works. He does a lot of research. He's part of the Therapeutic Development Network. His research focuses on clinical outcomes in patients with CF. He is a professor of pediatrics at the University of Cincinnati, and his clinical practice focuses on CF, chest wall disorders, and sleep medicines. Welcome, Dr. McPhail.
So hit a state. Yeah. Perfect.
I think by speaker 5, we will have it together.
So this will be about a 15-year review of the literature of how we got here and a little bit of data. So I have no disclosures. This is the regular disclaimer slide. So we'll be talking today about changes in airway clearance and nebulized therapies in children on elexacaftor, tezacaftor, ivacaftor, referred to it as ETI, otherwise known as Trikafta or Kaftrio. This is Ginger's data. So how did we get here? So highly effective modulator therapies, they're genotype-specific therapies for CF. So over the past 15 years, a lot of data to review. So initially, ivacaftor about 15 years ago, otherwise known as Kalydeco. Bonnie Ramsey and colleagues in patients with the G551D mutation reported fairly quickly on ivacaftor. Patients' sweat chloride values were cut in about half. Significant improvements in FEV1, lung clearance index, and other variables as well. Restored CFTR activity to over a third of normal. Taking an expanded clinical trial in patients with a G551D mutation, patients almost immediately had a 10% increase in FEV1, about a reduction in exacerbation rate of about 50% reduction. They felt better, so fewer respiratory symptoms, and they gained weight. And this 10% change in FEV1 is probably the threshold that I'll use for highly effective modulators that are included in this talk. Are these medications disease modifying? So some more data looking at the rate of decline in lung function compared to registry matched controls, and it cut the rate of decline in about half compared to patients not on ivacaftor. It's only for a selected few mutations. This is how we started. 5 to 10% of patients were eligible for ivacaftor Kalydeco. Took us a while to get to ETI. So in 2019, we finally had ETI came out. This is for one copy of Delta F508 or other mutations. So about 90% of patients in our center were eligible for ETI, had mutations that were eligible. Once again, sweat chloride almost immediately drops by over 40 points. On the bottom of the slide, the respiratory symptoms were a lot fewer in patients on ETI. In the upper right hand, that just shows there's almost no overlap between placebo and ETI-treated patients as far as the sweat chloride response. So kind of a powerful modulator of CFTR activity. In patients with one copy of Delta F508, lung function went up 13 to 14% over the first month or two, and that really held throughout the 6 months of the placebo-controlled clinical trial. Once again, very little overlap between placebo and ETI-treated patients in FEV1 response. Probably more impressively, almost an 80% reduction in exacerbations requiring IV antibiotics. So a really kind of transformative medication for many of our patients. How does this happen? So I think, is the CF airway on a highly effective modulator still the CF airway? This is some European data looking at almost 6,000 patients the year before and 2 years after starting ETI, showing a real significant change in infections. So a lot of gram-negative rod infections are reduced, Pseudomonas rates are reduced, Staph aureus, MSSA, and MRSA rates are reduced. Also some good literature showing reduction in mycobacterium infections and aspergillus as well. So very different microbiology for the treated ETI airway. This is some data from Lee Sawicki and colleagues also showing that similarly, as far as disease modification for the kind of the 2-year extension study, patients on ETI, they had that initial 14% absolute change in FEV1, and then the slope was really zero. So patients did not lose lung function in that next 2 years in the clinical trial on ETI compared to registry matched controls who lost about 2% predicted of lung function per year. So definitely a disease modifying therapeutic. And this is vanzacaftor, tezacaftor, deutivicaftor, otherwise known as Aliftrek, just showing non-inferiority compared to ETI. So similar FEV1 outcomes, a little bit of a reduction in sweat chloride comparison, but just the other highly effective modulator on the market. So what does this mean in 2025? That was 15 years of a quick review. So we have modulators that are highly effective to treat in our center about 95% of patients, so the mutations for patients. These modulators are getting very young. So ivacaftor is down to 4 months of age, ETI is down to 2 years of age, and then the vanzacaftor, tezacaftor, deutivicaftor right now is down to age 6. We're studying the 2 to 5s, and there's a trial design for the 1 to 2s. And so these medications are going to get pushed younger and younger for the majority of our patients, and it really is a very different world. Also showing since 2019 when ETI came out, there's been about a 20-year increase in median predicted survival for patients born today. So from 45 to over 65, might be up to 67 years of age. There's a more recent version of this graph that's not in here, but very impressive and quick transformation in outcomes. And so I think what we've learned too is that our patients just don't want these medications and ETI on top of their otherwise complicated regimen. So what they've been asking is for simplified treatment regimens. This is a kind of a CF community questionnaire of over 600 kind of patients and families and other folks in the CF community as to how do you find your pulmonary cares, what's burdensome, very or somewhat burdensome. And so they're asking for us to help kind of simplify their regimen. So obviously a lot of patients, more than half found airway clearance, inhaled antibiotics, hypertonic saline, Dornase alpha, very burdensome or somewhat burdensome. 80% of patients want us to study how do you simplify regimens in the ETI era. Also very quickly before any data came out, almost 1 out of 5 patients had already stopped a pulmonary therapy. So once ETI came out, people were reducing other things, even kind of front-running the evidence. This is Dave Nichols and colleagues looking at the PROMISE study. This is kind of extension study on patients that are starting ETI in the clinic space, in the research space. And very quickly, within 6 months of starting, without really any evidence, a third had stopped inhaled antibiotics. Now maybe their cultures were a little bit different, but also about a relative 10% had stopped azithromycin, hypertonic saline, and Dornase alpha. And so very quickly, patients were reducing the medications they were taking. This is an old reminder from Alexander Quittner that we prescribe a lot of pulmonary things for our patients and ask them to do a lot. This is a complicated medication possession ratio looking at over 3,000 CF patients. But basically, it's looking at refill data compared to prescribed medications, and patients were filling about half of the medications we prescribed, kind of across the board, really without regard to the burdensomeness on the other report. So we ask patients to do a lot. They're not able to do that much and probably only have about half their medications in hand. So even though patients were stopping, we still were going to do the simplified trials. So how do we safely kind of withdraw therapy in patients. So almost 1,000 patients ages 12 and older. For adults, the minimum FEV1 was 60% predicted. For kids 12 to 17, it was 70% predicted. So a very healthy population. Average FEV1 about 97% of predicted. Patients don't get into these trials if they've had an exacerbation or illness within 4 weeks. So it's a pretty healthy population going in. Patients kind of picked an arm to enter, was it Dornase alpha or hypertonic saline. They were randomized to stopping or continuing that therapy for 6 weeks. And this was primarily to see if anything bad happened kind of immediately upon withdrawal, just a 6-week study. And nothing did. FEV1s in the upper left hand, not really any differences or drop in FEV1. The study designers thought that if there was more than a 3% drop in FEV1 for the discontinuation arms, that would be probably significant. No real changes in lung clearance index on the bottom left as well. And so nothing immediately happens that we could tell physiologically when stopping either Dornase or hypertonic saline in patients on ETI that were relatively healthy. Just to be controversial, this is data from Donaldson looking at mucociliary clearance. And so fairly complicated, but in the upper right-hand side, there's only 17 patients here. 6 of them stopped Dornase, 11 of them continued Dornase alpha. And the conclusion here was that patients that stopped Dornase alpha had significantly better mucociliary clearance in the stop group compared to the start group. So it's another reminder that maybe the ETI-treated airway is not still the CF airway. We know that Dornase alpha and non-CF bronchiectasis has negative impacts on FEV1 and other markers as well. And so maybe we should be looking at these medications and regimens that we're prescribing. So a long review to get to our data in our study. We just have one airway clearance specialist, Ginger. She's been doing it since 2008. She has a pretty standardized assessment tool. So kind of one data collector and one assessment tool. We reviewed from 2018 to 2024, all the patient self-reported kind of annual airway clearance assessments. We looked at patients from 2019 to 2022. So ETI came out in 2019 for the 12 and olders and a couple of years later for the 6 to 11s. And we looked kind of 1 year before starting ETI and 1 and 2 years after. This is a very young group, so 6 to 14.9 years old. We needed 2 years of data of post data, so patients that were starting in 2022. We needed some 2024 data, and we need them not to have already transitioned to the adult care. So a young group in this study. We excluded patients who stopped ETI or didn't have complete data at all those time points. So we're a pretty large kind of quaternary level hospital with a moderate sized CF center, 240 CF patients. We transition our patients to our adult partners at about 19, about high school graduation. Have a lot of great centers in the Midwest, and so I think our hospital is bigger than our CF sample size. A lot of key metrics we looked at. So just the reported number of airway clearance treatments that patients are reporting on their annual assessment, routine use of Dornase alpha and hypertonic saline, kind of a yes/no variable. And then quickly looked at changes in FEV1 1 year before and 1 and 2 years after. This is just looking as quickly as possible as annual peak FEV1 for patients, not looking at quarterly. And we also looked at changes in IV antibiotic rate per patient per year, so exacerbation frequency. Had 100 patients in our sample size, 47% were female. The age that started ETI is exceedingly young, so 10.2 years. Baseline FEV1, a healthy population, almost 104% of predicted. Our center is very highly kind of Caucasian Delta F508 genetics, and so not representative of a lot of centers in the U.S. And the baseline antibiotic rate, was about 1 IV course per 3 patients, per year at start, so 0.31 IV courses per patient year. Almost all of our patients use a traditional vest with Minnesota protocol settings as their primary airway clearance to start the study. The FEV1 2 years after starting ETI, so 1 year before was 103.7%. There's a standard deviation there as well. It increased the average by 3% from 103.7 to 106.7 1 year before to 2 years after starting ETI. And the IV antibiotic rate declined by over 50% from 0.31 IV courses per patient per year to 0.13 IV courses per patient per year. And this is kind of a capture of the self-report. And we know that self-report tends to be an overestimate. So patients reported doing lots of things, more than 2 airway clearance treatments per day 1 year before ETI. 97% doing Dornase alpha. And I don't know if self-report's like double what people actually do, but there's some variable in there. And then routine hypertonic saline use. So reporting a lot of airway clearance, a lot of NEB therapies. Going to skip through the 1 year post because a lot of this 2020 data right around COVID. But 2 years afterwards, patients are reporting on average doing 1.5 airway clearance treatments per day, 84% doing Dornase and 50% doing hypertonic saline. So a significant reduction over time after starting ETI in their self-reported therapies. Before ETI, 100% of patients reported doing routine airway clearance. And by 2 years post, 15% reported not doing any routine airway clearance or any routine kind of NEB therapies. such a small sample size, 15 patients, so the numbers don't mean anything. FEV1 was really fairly stable in that group of not doing airway clearance. Exacerbation rates didn't change. They also noticed the FEV1 didn't go up and the exacerbation rate didn't go down. But these patients didn't have, obvious outcomes on the negative side. They may not have gotten the ETI bump that we expected. A talk for another day. I was looking at ETI as well as the vanzacaftor-tezacaftor current medication possession ratio. So really a complicated metric. Because I just have pharmacy data from 2025. But basically, there was a group that 5 of the 12 patients that I had pharmacy data on were probably super refillers. 91 to 100% of doses were in their hand. And then the other 7 out of 12 really had an average medication possession ratio of about 40%. So they were all kind of under 65% refills. In our center, about 85% of highly effective modulator doses are refilled if you look at refill data. How many are taken is a different question. There's some data from Syracuse and colleagues showing that patients take about 60 or 65% of their actual doses. And so we may have 2 different cohorts or 2 different groups here, at least in our center, in the not doing airway clearance or routine nebs. Some may be taking a lot of modulator doses and exercising, and some may not be doing a whole lot. So a quick discussion. So basically patients and our families and these young patients reported 27 fewer daily airway clearance treatments over time, 1 year before to 2 years after starting ETI. A 40% reduction in routine hypersonic saline use, and a 13% reduction in routine Dornase alpha use. Obviously, self-report tends to overestimate what patients are doing, so they're probably not doing more than they're telling us they're doing. Our data were really collected before the simplified trial. Results were known probably in parallel with the trial design and the trial going on. So we knew the trial was going on, but we didn't really know the data, quite yet. But patients were already de-escalating care. A lot of other variables over the past 6 years. So, COVID-19, played a big role in kind of 2020. That's why I avoided some of the 1 year post and 2020 data. Our patients are doing less of everything sometimes. So fewer vaccinations, fewer things, whether that's political climate or kind of trust in science or healthcare. ETI is not the only variable kind of in play here. Our patients over the couple of years reported about over 10,000 hours less of airway clearance, which is significant time savings. I think fewer medications equates to a cost savings. What's the regimen of the future? What's the long-term risk of simplifying your regimen is not particularly known, but I think we do need to design some evidence for the future as our babies are starting highly effective modulators very early. What should we be doing? I think we don't particularly know what the right regimen is. These shifts in treatment are kind of complicated. They may reflect family preferences and or medical recommendations from the care team. So kind of a bidirectional relationship in the clinic. Some shared decision-making and variations in care. In my own clinic, I think usually it's families that are asking to reduce things, not so much the clinicians, but it is definitely shared decision-making. And at least based on our data, we think that these annual airway clearance assessments capture kind of real-world self-reported treatment patterns. They inform our clinical practice, and they definitely can support future research that is needed for studying this group of patients that really reports doing nothing, who's in that group and are they at risk of negative health outcomes, but also just letting us know, what patients are wanting to do and what kind of trade-offs they feel are reasonable with kind of the time and the cost invested in care. Limitations, so single center sample size, we're a very homogeneous center, a lot of Delta F508 and Caucasian self-reported patients. It's a pool of patients, some were modulator naive, some were switching from ivacaftor, some were switching from the dual combo modulator. So it wasn't just one type of patient in this group, it was all of our patients. And definitely not designed to assess changes in exercise patterns over time, knowing half the audience is physios. We ask a few questions about exercise, but it probably wasn't ready for prime time in this kind of data analysis. And I think that is all. I think we can take questions.
I'm thinking the microphone has been fixed, so we do not have any questions in the app.
That's good.
Please review what you said on the Palmazine stopping.
That's complicated, and so I don't think we really know. I think what we know is that in Pulmozyme or Dornase alpha, in non-CF bronchiectasis, there has been studies showing lower FEV1, even higher mortality in patients on Dornase alpha. I think Scott Donaldson and their group, they were trying to study mucociliary clearance in patients either in that simplified trial, either staying on Dornase alpha or stopping. It was a very low sample size, only 17 patients total. I'm not sure I should draw real conclusions from that, although it was statistically significant. Patients that stopped the Dornase alpha actually had better mucociliary clearance compared to the patients that stayed on it. And so it's a hypothetical and kind of controversial question, which was fun to throw in. We're using these old medications we studied in the CF airway that before modulators, and not only might they not be beneficial? Could some of this be a little bit harmful for patients? So should we be really re-looking at these types of medications in a larger sample size? And so that always is a bit controversial to bring up, but I think as clinicians, we often just continue the prior regimen, not really thinking that maybe there's some deleterious effects as well.
So I know that in our center, we have some of our pulmonologists actually, allow this de-escalation of care. They take a medicine away. They stop hypertonic saline. Is that similar in your center? Is that?
It probably depends on our clinicians. We have 7 or 8 different CF clinicians. I would say in my own personal clinic, families are often asking. We had a lot of patients in the Simplify trial. I think for a lot of our patients, we try to encourage 1 good airway clearance session a day and 1 good cardiovascular exercise session a day. So probably have gotten away from recommending 2 perfect airway clearance sessions if you're doing good cardio. Now, not a lot of our patients do perfect cardio. We have some cross-country runners and soccer players and basketball players, some that are really doing it. The reason we didn't include a whole lot of exercise data in here is that our questions going back that far, going back almost a decade, were really, do you exercise routinely? Yes, no, and everyone says yes. And then how many days per week? And it went from 4.5 to 4.77, so patients were reporting more days per week of exercise. But then when you talk to families at the granular detail level, running around the park, going outside, gym class, any activity is considered to be exercise. And so we didn't find that to be very kind of robust data. And I haven't had a whole lot of patients that I've asked them to stop their Dornase, but maybe I should. I've had patients in the Simplify trial. One was a college cross-country runner, withdrew from hypertonic, withdrew from Dornase, stopped doing airway clearance. I think she's still doing probably fantastically. So she's now in our adult center and as a mom. But I think will be some families, especially as patients get a little bit older, and they have more time crunch, they're going to be asking to reduce these. But Felix may have some ideas. I don't know what's happening in Toronto. You came to hear the Toronto talk, not my talk.
No, I'm not going to do that. And I'm not going to comment on Scott's statement itself, right? I just wanted to say, you put in a good statement about saying that we actually need evidence. And we're in the planning stages of the REACT study, which is rethinking early airway clearance therapy, which is going to hopefully address that question to see that whether you continue hypertonic or Dornase alpha versus not, whether that has any impact on the longer term. So
yeah.
So hopefully we can start this study next year and then we'll get some evidence.
Yeah, I think unfortunately as clinicians, our pattern is often just to add things on. And so, you add more medications on, more therapies on, and you just do that for a lifetime. And so I think we need a different mindset and some data for what we should be doing kind of in this day and age. It's a whole new era. Cool. Awesome.
Okay, thank you.
Great. Okay, so Claire Crompton will be coming to talk next about adherence and perspectives of CF patients on airway clearance before and after ETI. Claire is a clinical research project coordinator at the Hospital for Sick Children in Toronto. She works within the Division of Respiratory Medicine, supporting a range of research studies under Dr. Ratchin. And her work contributes to advancing pediatric respiratory care through evidence-based research and collaboration. Please welcome Claire.
So thank you for inviting me to discuss our project. I'm presenting on behalf of our team, and again, I'll be discussing the adherence and perspectives of CF patients and caregivers on airway clearance therapies before and after elexacaftor, tezcaftor, and ivacaftor. So my name is Claire Crompton, and I have no relationships to disclose related to this presentation. So as we know, introducing highly effective modulator therapies has greatly impacted pediatric cystic fibrosis patients and caregivers. And these therapies have helped reduce pulmonary exacerbations, improve lung function, and have resulted in children with CF feeling better for longer periods of time. And currently, airway clearance therapies are a cornerstone of CF care. However, it can be time consuming, and when patients begin feeling better, they may reduce their compliance to therapies. So our objective was to investigate the adherence of pediatric CF patients to their ACTs and to gather the perspectives of pediatric patients and or their caregivers on their ACTs after initiating ETI therapy. So for this project, participants were recruited from an ongoing prospective study, which involves children with CF who have been clinically initiated on ETI therapy for more than 6 months. The patients or their caregiver completed 2 surveys at back-to-back clinic visits. The survey at visit 1 asked about airway clearance prescription, techniques, and inhaled mucolytic or mucoactive therapies in the month prior to initiating a CFTR modulator, as well as the post-ETI prescriptions and practices. And then the survey at visit 2 is the same as the second half of visit 1, focusing on airway clearance therapies currently prescribed and performed. So our survey, the questions were modified from the Medication Adherence Report Scale, or the MARS-5, with modifications to the wording. So for example, we took statements such as, I took it every day, and revised it to, I did it every day. And in addition to asking about airway clearance prescription and practices, participants and their caregivers were invited to complete an open-ended question, exploring challenges associated with performing or completing their airway clearance therapy. And the responses were independently coded by 2 reviewers to identify recurring themes, with a 3rd reviewer resolving any discrepancies. And the themes are based on patterns observed across participant feedback. In addition, we also completed chart review. This was done to confirm data on airway clearance prescriptions and captured healthcare provider comments on adherence. And the chart review covered 1 year prior to the modulator start date and continued until the date of the second survey. And then adherence-related themes were coded independently by 2 reviewers to ensure reliability with coding conducted in duplicate. So our participant characteristics. A total of 40 participants were recruited during the study period. Of these, 18 or 45% were female, with the mean age of 8.9 years at the start of ETI. And most of them had been on ETI for at least 2 years. So 27 of our 40 participants were prescribed hypertonic saline pre-ETI, while only 22 of the 40 continued on this form of therapy post-ETI, though this change is not statistically significant. And in contrast, those prescribed Dornase alpha declined from 14 of the 40 pre-ETI to only 6 of the 40 remaining on this form of therapy post-ETI, which could be considered a statistically significant reduction. So this is our self-reported adherence from the questionnaire. This figure illustrates self-reported adherence to airway clearance techniques pre and post-ETI. And all participants in the study are prescribed at least 1 form of airway clearance. And a positive note is that although exercise is not formally prescribed, it is routinely encouraged as part of overall care. Patients and their caregivers reported high adherence to physical activity, reflecting strong engagement with this aspect of their airway clearance pre and post-ETI. And then this is the adherence. This is where we see the adaptation from the MARS-5, specifically targeting adherence to prescribed airway clearance techniques. And while no statistically significant observations were noted pre and post ETI, we do note some minor shifts in altering the therapy frequency in patients who stopped doing their ACT for a while. And this could be reflective of the changes to ACT prescription post-ETI. However, it can also be suggestive of evolving adherence behaviors following ETI initiation, where patients may choose to alter their therapies based on how they feel rather than following their prescribed therapies. And then this has to do with the inhaled mucolytic or mucoactive therapies like hypertonic saline and Dornase alpha. Again, we use the same adapted questions from the MARS-5 to ask about adherence practices, and we have some suggestion of decreases in regular use and perhaps some increases in those who stop their inhaled therapies altogether. And as we saw in our participant characteristics, we do know that some children were no longer prescribed their hypertonic saline or Dornase alpha, while others were advised to use them only when symptomatic rather than on a daily basis. And these changes reflect a shift in clinical practice and patient adherence patterns post-ETI. And now we have our provider observations on adherence. So, So these were transcribed from clinical notes documented by our physiotherapist, and given the frequency of clinic visits, so approximately every 3 months, and the 1-year-long data collection period for pre-ETI observations, some provider comments were sourced from the patient's physician as well. So post-ETI, there was a notable increase in provider document instances of patients not performing their ACT regularly, which contradicts the self-reported adherence from patients and their caregivers. And this could be a result of numerous patients who are no longer prescribed maybe their mucolytic or mucoactive therapies. And we do note that there is a jump in patients doing ACT when unwell. And this could be represented by our population that were prescribed their inhaled therapies when symptomatic, or those who were suggested to increase their techniques when unwell. And then again, we observed an upward trend in the reporting of exercise as part of airway clearance practices. And again, although it's not formally prescribed, it's routinely encouraged. Its increased reporting suggests continued engagement in physical activity among patients receiving ETI therapy. So now we're going to jump into the question that we left with our patients. So we asked them, what do you think are some challenges to doing your or your child's airway clearance therapies as prescribed? 62% of respondents reported that it was too time-consuming. This was followed by 42% noting that a busy lifestyle interferes with adherence, and 35% reporting difficulty maintaining focus or engaging their child for the duration of the therapy. Additionally, 27% indicated that feeling well reduced their perceived need for ACT, and 23% found the therapy boring, while 12% were unclear about its benefits, and 6% felt that exercise alone was enough. And now in the following slides, we're going to highlight our top 4 categories and share some of the feedback we received. So one patient noted that it was too much work and it takes a lot of my time. One person noted that finding time to do it well together and prioritizing it, it's challenging to commit the time, and school makes it tough to do in the morning. So the prescribed 2 times a day is not done as often. For busy lifestyle, now that they're in high school and a competitive athlete, it's hard to fit in the a cappella at times, but they work hard to find time and manage. This patient said that they don't have a lot of free time to do it. They dance 4 to 6 hours, 3 to 4 times a week. They work 3+ times a week, and they go from school right to dance and or work. And this caregiver noted that when going away, such as camping, there's no way to easily sterilize, so we changed to percussion as an alternative. We felt this one was kind of cool to include because although they're not following their prescribed therapy, they are finding an alternative, so that is kind of a positive as well. And then hard to focus, he's 3, his independence can be a hurdle. If he's not feeling like doing his physio, they break it up and come back to finishing it. And this patient is finding it challenging to be motivated to do it. They would rather be playing or reading. And cooperation by child, they don't want to do it or is easily distracted. And getting her to sit and focus on the therapy for the required time and getting into a proper rhythm or timing for it. And then for feeling well, the age that she is, and she doesn't see symptom, so she doesn't realize the importance of her therapy. This results in a lot of arguing to do the therapy and her not always putting in her best effort. And the reason I do not do the mechanical airway clearance is because I feel fine, and even when I do it, I do not feel anything. And because she's very well at baseline, she doesn't see the connection between PEP and long-term wellness. It doesn't feel any different to her before or after PEP, so it's hard to see it's worth her effort. So we did have some limitations with this project. One limitation was that we had a relatively small sample size, with only 40 participants recruited during the designated time frame. So we aimed to complete the Survey 1 and the Survey 2 within 6 months, which limited our ability to approach all patients followed in our prospective study cohort. And secondly, while we tried to include all eligible individuals, certain families were not approached due to complex personal or clinical circumstances. And these included cases involving changes in custody, which impacts the recall period, social challenges that made discussions around adherence sensitive, and situations where the clinical context made participation in a research study less suitable at the time. And it is possible that these families may have had lower adherence rates, potentially leading to an overestimation of adherence in our findings. And thirdly, the study did rely on participant and caregiver recall of prescriptions and practices prior to ETI on initiation, which on average occurred 2 years before enrollment. So this introduces the potential for recall bias, and to mitigate this, we supplemented self-reported data with the chart review, including provider impressions on adherence to enhance the reliability of our findings. So to conclude, self-reported adherence to airway clearance therapies remains high among children with CF receiving ETI therapy. However, healthcare provider observations suggest a decline in adherence, and strategies for patient engagement and flexible prescription models would be important to consider in the era of highly effective modulators. And finally, we would also like to thank the children and families who participated in this study for their time and support and continued support. That's it.
I'm not sure that the app is receiving new questions, so if we have questions, please come to the microphone.
I just was curious about your physical activity, because I also saw that the providers thought that the physical activity was very high, and then the kids did as well. It sounds like your adherence is much higher than most of the centers in the US that I'm aware of, but do you think there's a bias towards kids and their parents reporting that they're exercising more if they're kind of dropping off with their airway clearance because they know exercise could be a form of airway clearance? Because I sometimes wonder that now too, if people are just saying that because we're a little more lenient. If people are good lung function and they're doing something, as long as they're stable, we're not pushing as hard with the airway clearance. And I'm just curious if you think that both receiving that message and giving that message, and people might be fudging it a little bit. So I guess it's my question.
Potentially. Yeah, I don't know. It's hard. I did the questionnaires with all the families, so getting them to answer exercise was kind of awkward. They were like, what does count as exercise? And I'm like, well, what are you doing on a day-to-day to make it sound like exercise? So a lot of them are reporting, I mean, they're competitive athletes in hockey. Some of them are runners, dancers.
But did that change? Yeah. Like, if they were doing that, they probably already
doing it, yeah.
The ones that are really competitive.
Yeah, I don't know. This is Blythe, our physio.
There, the team there. And Holly, to answer your question, I think many of them subjectively had told me that they feel a lot better. They had more energy, and so they were able actually to participate in more physical activity. It may not have been quantified, but I think when we looked at the charts and such, it was, kind of things that we listed. Well, actually, we did quantify the number of times they had done it per day, per week.
I'm not gonna bother going over there. I know. Both of my kids had CF and they have two different kinds of vests, and you can track the data and see how many hours they've been on that. Has there been any thought to using that information rather than like, well, how often are you doing your airway clearance?
So we don't use the vest in Canada. So, and there's no way to track it on like their PEP or anything. So it's hard, I guess, to answer that question. By not having the vest. Yeah, sorry, Blythe.
In terms of adherence, I suppose it is a little bit more subjective, but it's different. Sometimes the patients will give different information to the different healthcare provider. So we standardize it by, I really actually go through all of their airway clearance with them and see how they're actually doing. But we don't use the vest very much, so we don't have the quantifiable measures with your amount of time and settings that you guys use.
Blythe, I don't think they can hear you. I don't know if you want to stand with this mic.
You're welcome to come up here.
Perhaps. Yeah, this one works.
This one's working.
For people who want to ask questions.
Is it working now?
It is.
Okay.
Quiet.
I was trying to say that we don't use the vest very much in Canada, but when we're looking at airway clearance and how they're actually doing it and adherence, I actually meet with them during their clinic visits, have them go through the number of cycles, the technique to make sure it's very good and also effective, because we know about Project Physio and how quality is important in terms of effectiveness of their airway clearance. Does that answer the question about objectivity?
Yeah, I was just curious, we have all this data, but obviously that's more than
And why we don't use the vest is from the PEP study comparing to high-frequency chest wall oscillation published in 2013. It was a 1-year long-term study that looked at the differences between using those two techniques. It was initially a safety study that we were looking at, but we did see some signals that the group in the high-frequency chest wall group, it was statistically significant, had more pulmonary exacerbations. So from that perspective, it was not the choice of airway clearance for Canadians. We also have different insurance policies as well. So the vest actually isn't insured for Canadians. But it is also best practices in terms of what we found.
And one thing I'll say about using like the either the electronic monitoring that comes with a lot of vest systems today, or even asking patients to bring the equipment in or report that number to us, is we're not real successful with that. So sometimes just getting them to come to their appointment is a problem. So if they got to bring their vest, they'll bring their vest if they want you to check on the size or help them program it. But if they feel like you're going to be checking up on them, that's kind of rough for your dynamic, because if you're asking them what they're doing and then you're wanting them to prove it to you, that is probably perceived as a negative. And then one of our esteemed pulmonologists, when I was really excited when we had these reportings, look, I can get online and see how much they're doing it. He's like, they could be putting it on their teddy bear, or just running it, just running it, because if they think that you're going to be checking up or seeing how often they're using it, they're going to make those numbers say what they want them to say. We've asked patients, how many hours a month do you think you use your vest? And some of the numbers you hear are pretty outlandish. 1,000 hours a month.
Find out.
And yes, now that does happen occasionally with patients, and try not to use that as a tool to say, hey, your insurance company may call and check, because I think savvy patients will they know how often they're supposed to use it, so they will report that number.
I also noticed that in your study that only 14 out of 40 were on Dornase. Is that a Canadian thing too, or is there a time you have to start? Because I think we're using a lot more of it in the United States.
I'll let Felix handle it. Sorry.
Yeah, overall, there's less use of Dornase alpha in Canada versus the US. And it was interesting because when all these discussions happened about survival in different countries, and in the UK, they were saying we are using less Dornase, maybe our survival is less because of that. In Canada, it was actually more than in the US, and we were also using less Dornase alpha. So building these relationships is always a bit difficult, yeah. But in terms of the reduction of Dornase alpha, is that there might be a bit of a bias that because of the non-CF bronchiectasis story, that it might actually be deleterious in that setting, and because of the wonderful data that's got created, so that there might be, so in terms of that if we have these discussions with family, what should you discontinue? We often say, well, from our perspective, it probably should be the Dornase rather than hypertonic. Thank you. Sorry.
Okay, well, thank you.
Very much.
Finally, the mic.
All right. So we have our final speaker coming up. We're probably going to finish a little early. I think the audio is working, but we are not receiving questions in the app unless nobody has asked one for the last three speakers. So please don't hesitate to come to the microphone if you have questions. Our final speaker is Holly Lucen. She's a physical therapist at Johns Hopkins. She has specialized in CF care since 1994. Holly has co-taught CF continuing education courses and has been active at NACFC as a speaker, session chair, and as a current member of the program planning committee. She has presented widely to medical professionals and families on CF-related topics. Her additional clinical interests include the care of medically complex children, particularly in the NICU and PICU, and cardiac populations, as well as pediatric trauma and burn rehabilitation. Welcome, Holly.
I want to thank Sean and Andy for inviting me to speak today. And we're going to kind of build on some of the data that Sean was showing you in the first the first presentation, and we're going to talk about exercise capacity and how it's clinically marked by physical activity and sport. No, I have no relationships to disclose. So traditional CF care management has always relied on FEV1 as the primary marker of CF health, but with the advent of CFTR modulators and as CF care continues to evolve, we find many of our patients, as we've seen in all these talks today, are maintaining normal to near normal lung function. This is especially true in pediatrics and for our adolescent population. While the FEV1 provides a great snapshot of lung health, it doesn't tell us enough about the real-world functional health status. Exercise testing may offer a fuller picture since people with similar lung function may differ significantly in how they perform day-to-day activities and in their functional health. And you're going to see that in some of the slides ahead. So we wanted to ask, what are the drivers of exercise capacity? And what things can we ask and do in a short clinic session? What can we be asking our patients to guide our interventions and inform our care? So this leads us to our objectives, which our first primary objective when we started this was to see what related to exercise capacity as far as could we relate weekly minutes of moderate intensity of activity to A-step performance, or the Alfred Step Test exercise protocol. And we also wanted to see how participation, because for pediatrics, it's not a bunch of like repetitions and what you're doing for exercise. That doesn't go over as well. So it's more like, what can we do actively for play or for sports? So we were looking at sports and structured exercise to see if that actually related to exercise capacity as well. We also secondarily wanted to look at the associations between the A-step performance and lung function, as well as the AUS score, or the Alfred Wellness Score, which is a quality of life assessment that we also started in our clinic around the same time with this age population. We also subsequently looked at CFTR usage and routine airway clearance. So these people, all the data that was collected was during a routine annual PT assessment. So we see all the people in our clinic annually, at least annually. We had 74 people, but performed 86 assessments because this was collected over the period of about a year. So 12 people were going on to their second annual assessment. This included the A-step and the AUS score, and we also looked at the lung function data from the day that we collected this data. Activity was self-reported by the families. We would ask them about their weekly, this is part of routine physical therapy, how many weekly minutes of moderate intensity activity they were performing on a regular basis. And we also asked if they were involved in sport or structured exercise. We did define this, but in our study, someone could be doing ice skating once a week or twice a week, or it could be someone who was doing every day, like club soccer and, hours a day of activity. So the sports is just if you were doing it. If they did both sport and structured exercise, which we'll get into the difference about those two in a little bit, we classified them under the sport category. So Sean already went over this, but it's incremental step test is the A-step. It's a max exercise test, or that's how it was in the adult population. Starts at 18 steps a minute, increases at a rate of 2 steps every minute, and the test ends when the patients are at exhaustion or when they complete level 16. Sean outlined the max effort criteria for this. We looked at what I'm going to see the slides ahead are the max performance of what the kids did in our clinic, but we also recorded what their max physiological effort was. So we also have data about when they hit that 90% max heart rate and also when they achieved the 9 Borg for dyspnea or leg fatigue. So just another quick review on the AUS score for people who aren't familiar. It's a patient-reported outcome measure of general wellness. There's 10 questions across 5 domains, so there's 2 questions per domain, and each question is answered with a numerical rating from 0 to 10. It's a very quick quality of life assessment. This is the sample that patients would receive either physically on paper or was collected online before clinic or at their clinic appointment. And specifically, they filled out everything, so we had a total AUS score, but we were really looking at the 2 physical domain questions where I rate my level of energy as, and I rate my level of exercise participation as. So additionally, we categorized what they reported for physical activity. So again, these were self-reported weekly minutes of moderate intensity of activity. We categorized them in the low category if they had less than 150 minutes a week. They were in the medium category if they were 150 to 300 minutes a week. And if they were greater than 300 minutes a week of activity, we classified that as a high activity level. And you can see the percentages of our population that were in each category. For participation in sport or structured exercise, again, you can see the percentages of people that were in there. Sport is anything that had organized oversight. It also was led by like a leader or a coach, and there was accountability. You were expected to show up, you were expected to do something. So again, obvious things like soccer, basketball, football would be included in this, but also marching band, maybe a high school musical, something that you were doing a lot of activity that was led by a leader. Structured exercise was not, we actually categorized this as we started this because we realized some people weren't doing coached activities, but they were regularly running or doing other things on their own, going to the gym. So we categorized structured exercise for people that did self-directed but no oversight, and again, had to be doing this routinely. So those were our two active participation roles. So other important demographics to note, we also, although some people had even higher than us, had a high CFTR modulator usage. 85% of our people that were tested were on a modulator, and 80% of our total population was on a highly effective modulator, so ETI or ivacaftor. The lung function was also high. Our mean was 97%, our median 99%, and we only had 6 of our participants that had a lung function less than 70. We also looked at routine airway clearance, and I'm going to tell you, I was actually a little surprised that it was as high as it was, but 53% of our patient population were still doing routine airway clearance, excluding exercise. We did not include exercise in this when we were asking about airway clearance, although we do teach that as an airway clearance strategy. So we did have about half of our population was doing some form of routine airway clearance other than exercise. So this is where we get to the good part. What did we see? We really wanted to see what mattered most. What were the predictors for exercise capacity? And so here is our big chart here. So these are the predictors of A-step performance. Your independent variables are there on the y-axis or to your left. These were all the things that we looked at to see what kind of effect they would have on the A-step performance, which was defined by the level that they completed. So you will see the regression coefficients here. The blue are bars that represent statistical significance. The gray did not reach statistical significance. So you can see organized sport and 150 minutes or greater of activity had a really high regression coefficient. This was a 16-level step test, but our organized sports, if you did sports versus the people that didn't, you were predicted to do almost 3 more step levels than your peers. For 150 minutes of activity, that was 2.5 extra step levels than your others. Structured exercise did not reach statistical significance. I included the p-value there, but it did trend in a positive direction. Again, had a pretty high regression coefficient, but just limited significance. FEV1 is at the bottom, so it did reach statistical significance, but if you can see visually the difference in that coefficient, it's much smaller. So the effect on your exercise capacity on this Alfred step test was 0.057. So I think somebody had that question in the app, so there you go. Now looking at our charts here, we're going to break down the activity. So again, low activity is on your left, high activity is on your right. For people that aren't familiar with box and whisker graphs, you can see the median is represented by the horizontal line and the mean is the X. What's interesting here, I think visually you see it very clearly that the 2 higher levels of activity did better, but also that the median, again, the median for the low exercise group was 7 step levels. But if you go up to the higher activity group, they're already at a 13. So that's a 6-step difference. And again, this was statistically significant. The differences between the medium group and the high activity group did not reach statistical significance. Similar picture, almost looks like the identical graph. for sports and structured exercise versus no sports represented by the yellow. You again can see the medians in this very similar. It's a 7 steps for no sports, and you're up to 13 if you're involved with sports. And similar response to the structured exercise. Again, this was good significance, but no difference between the sport and structured exercise groups. Okay, and I really like this graph too, but bear with me as I try to explain it. So you have percent predicted FEV1 on the bottom, and we have the A-step levels completed on the left or on the Y graph. The colored dots represent 2 different levels of activity. So again, the blue dots are the people that reached at least 150 minutes of activity or the 300. The yellow dots represent the people that were under that. So this is a good visual representation of, you can see that the blue dots are more towards the upper part of the chart because they had the higher A-step levels. The yellow dots fall towards the bottom because they had less A-step performance. And the 2 different trend lines, again, you can see the difference for the people that had just 150 minutes of activity was different than the yellow. The R value and the P value that's represented there, though, is the collective of both of those groups, which again reached significance. This next chart, similarly, now we're getting into that self-reported, the quality of life information. So this was on that physical domain. We asked that exercise participation question. 0 to 10 score is on the bottom on the x-axis. On the y-axis, you have the A-step levels again completed. The dark squares are people that were participating in sports or structured exercise, and the pink ones were the people that were not involved with any sports or exercise participation. Here we found a moderate positive correlation. And again, this is suggestive that the self-ratings of exercise reflect the actual physical performance. You again can see that the people with the dark squares are tending towards the higher AW scores, towards the right, and the pink have a little bit more going towards the left or the lower AW score participation. So this was nice to know that what they were reporting was actually reflected in what their test results were. AW score energy was same thing. The energy, I rate my energy as score is on the bottom. The A-step levels completed as on the left. This was also significant, but it was a little bit weaker association compared to the self-rating for exercise participation. And it had a moderate positive correlation. I threw this one in just for fun for all you airway clearance people out there. Our routine airway clearance actually did worse visually than our no routine. This was not statistically significant, but interesting nonetheless for people that are wondering about cutting back on airway clearance. Our no airway clearance group actually performed better, but not statistically. So our key takeaways here. Physical activity and sports participation strongly predicted exercise capacity for our cohort. But FEV1 only showed a weak correlation, which again, FEV1 is good. It's nothing wrong with FEV1. But exercise test performance also aligned very well with those AW scores and the physical domain for exercise and energy. So again, these are the self-ratings, the self-reports of our teenagers and adolescents on what they were doing. So even with high lung function and or modulator use, activity level differentiates performance. If we went back to that lung function chart with the yellow and the blue, many of them had the same exact lung function, but you saw the difference in the people that were actually active performing much better. So activity and sports matter. FEV1 does not tell the whole story and should not be the thing that we're using to solely define health in our CF population. I would say anymore, but probably always was never supposed to be the end-all be-all that we have somehow made it. But this further supports that for our cohort, exercise capacity was more influenced by modifiable behaviors than lung metrics. So what were our limitations? This was, again, as other people have reported in their abstracts and stuff that they reported today, this was self-reported. So this may be subject to bias for some of their weekly activity minutes. The sports, like I said, we took that pretty liberally, so I think that was pretty accurate. A-step max effort thresholds, although you were looking at the max performance on the graphs you saw today, you have to wonder if this is a maximal exercise test for this age population, because we think that they may be underrepresented. due to the fact that we had so many people complete the test. And our cohort actually also had high lung function and high usage of CFTR modulators, which may limit its generalizability. So what are we going to take away from this? 150 minutes a week of moderate intensity activity is a meaningful, achievable target. Why is this important? The WHO, the CF Foundation, everyone, this is lower than what they're actually recommending. So for unless you're an adult would be 150, which would be 18 and up. But for our 17-year-olds and under, they're supposed to be getting 60 minutes a day. That's 420 versus 150. But we saw meaningful results with just 150. Sports and structured exercise actually outperformed unstructured activity. So let's start thinking about ways we can introduce structure into some of our pediatric patients at a younger age. Working on behavior-focused guidance can and should begin early. So I know for our young kids, like even babies, one of our first discussions, like you're introducing yourself, but we're talking about, really want to get your kids on an active pathway, get them involved with sports or in, routine things that you can do. And there are resources out there. Breathe Strong. There's activity grants if your patients do not have access or the resources to sign up for league fees and stuff like that. Look into some of these things for them. And the OSCOR correlating well with the A-step results is a quick and useful clinic tool. So maybe you don't have the capacity, maybe you don't have PT, maybe you don't have the ability to do some exercise testing. Maybe just using some of that data to highlight the people that are most at risk, the ones that have the lower OSCOR, will help guide you to some better results and better health results moving down the line. So we need to ask and act. So simple activity screening can inform care. We should feel confident using both this objective and patient-reported measures to drive our conversations around activity and help our adolescents and kids to hit their meaningful activity levels to improve their exercise capacity. And I want to thank our Johns Hopkins Pediatric CF team, which includes Sean, who spoke earlier today, and our incredible adolescents. You can learn more about this if you attend this poster session or go to the posters. I'm poster 509, but we also have posters 497, which are looking at A-step feasibility in the pediatric clinic. And 604 is the correlations between skeletal muscle mass, BMI, Z-score, and exercise capacity in the pediatric CF population using a BIA. And that's it. Hey.
Amazing. I loved your presentation.
Oh, thank you.
Your topic. How did you do with explaining to patients moderate intensity? Because I always struggle with patients that are like, oh, I exercise every day, and then they're taking like a casual walk, which is good.
Yeah.
So I was just wondering if there was a good way that you explained to your patients what moderate is.
We had a lot of discussions about this too,
Yeah.
but I don't think we had collectively a great way. I usually say when I'm talking about moderate, something that makes you breathe harder, might make you sweat a little bit. We do count like this short burst of things. So if you're doing stuff, so we would talk through some of the activities and seeing what they're doing to classify that. But we did have some discrepancies. And we actually had some kids that I felt were a little harder on themselves. There was somebody who was playing baseball pretty competitively all the time, but he was saying, well, I don't think it's really moderate, but you are running on and off the field. You're doing things like, I felt like he was selling himself short. So sometimes it's even the opposite of what you think it was, but
because
I don't
usually
have
kids in sports, I feel like is probably automatically moderate. It's more the adults that are doing slower exercise.
Yeah, but it's the sweating a little bit or breathing hard is usually what I use. But I don't know if that's actually the best way to do it either.
I like it. Thanks.
Yeah, no problem.
Thanks, Holly. I have one on the iPad.
Okay, good.
Is this working? Will your data change your clinical decision-making about who you do the A-step test with? For example, if a patient participated in greater than 150 minutes of physical activity per week or an organized sport, would you focus your PT sessions on other outcome measures?
Great question. And yes, that is what we're trying to drive right now. We try to capture all of our patients the first time around, so we had baseline. And I think Sean alluded to this earlier too. If they were maintaining their lung function, there has been no changes to their physical health, and they're still reporting the same amount of activity, then we're kind of like, we're not going to repeat the test the next year. Now, we might if something changed. If there was a change, they've had an illness during the year, a significant illness, something has changed in their lung function, or something has changed in their behavior pattern and they're not as active as they were, that's when we would go to the test and repeat it. But we are still, this is brand new. We just started this test last year, but these are conversations we're having now and kind of how we've been driving ourselves. I think Sean mentioned earlier too, going back and looking at people that had leg fatigue. That was the reason they ended, but they still might have done very well and they're active, hitting their activity levels that we think are good. We might focus more on, hey, have you thought about doing some strength training? Something like that. So yes, for sure.
Got another one for you. What do you recommend for teenagers who do unstructured exercise and do not wish to join structured sports?
Wow, I would have $1 million if I had the answer to that question. Yes, you just have to do the best you can to encourage and motivate. But I'm not great. I'm not going to say that I have the answers to that question. I'm a huge believer in opportunity, like giving yourself exposure and opportunity to a lot of different things. So having those conversations, those PEP-driven conversations, what things interest them, like making sure they have to be at a ready state to be able to do this. If they're not ready to make change, then you can browbeat them till you're blue, but you're not going to change it. So you have to get them to kind of see the benefits of it. And then again, give them a lot of, if they can't come up with something, you can give them some ideas, but if they're not ready for it, they're not going to switch over. You just have to kind of keep building on it every time you see them, a little bit at a time. All right. Thanks, everybody.